Hello and welcome to Raider HQ After Dark. I'm your host, Raider. And in today's video, I wanted to talk about prostate cancer. So we're going to be going through how prostate cancer is rated. Now, I'm going to upfront tell you that this is a very complex condition that can be claimed because there's a lot of caveats to it. There's a lot of ins and outs. So this might be one video that you might have to watch more than once. So it does behoove you to watch until the end because what I'm going to be doing is I'm going to be giving examples of how the VA defines prostate cancer for VA purposes. So just because, medically, you can have it medically diagnosed, but that doesn't necessarily mean that the VA will recognize it. So I'm going to be educating you all on how prostate cancer works. Now, we're also going to be talking about how prostate cancer is different than most other disabilities in that the treatment will dictate when your routine future exam is. So we're going to go through each one of those. I'm also going to do a little spreadsheet type thing to tell you and inform you as to how, like what theories for service connection can be applied to prostate cancer and which ones can't. Then we're going to go through how is it rated, and then we're going to go through the DBQ for it, and then we're going to give you some practical examples of kind of what happens. So this is one of the videos, like I said, that you're going to want to watch throughout if prostate cancer is important to you, one of your family members, or just in the future, if you're just researching this just in case, you want to watch the whole thing. So let's go ahead and get into it. And I'm going to apologize up front because my neighbors have synced up with me somehow, no matter when I do a video, day, night, doesn't matter, that they will let their barking dog outside and it just upsets my dog. So, but I digress. So let's get into this. Okay. So each one of these manual references will be in the video description. But this is, if I can tell you, like if you can take one thing away from this, is that prostate cancer, in order to satisfy element 1, the current diagnosis, which element 1 is true for all theories for service connection. Element 1 stays the same. It's always a current diagnosis. If you read this M21-1 entry, it says a diagnosis of initial, and I'm going to say this initial prostate cancer is made only on the basis of a prostate biopsy. An elevated prostate PSA level test is not diagnostic of cancer. So you cannot, for the initial, now I keep saying initial, it doesn't say initial here, but this is important. For the initial diagnosis, you must have a biopsy. Now, I understand that there are a lot of veterans out there, and probably more than you're aware of, that decline the biopsy because they see it as an invasive procedure. However, if you want to get prostate cancer service connected, it doesn't matter how certain your doctor is that you have prostate cancer. You could have 1,000 PSA level. It does not matter for VA purposes. This is not something they will yield on. The VBA, at least, will not yield on this. This is a mandatory requirement. The terminology here is made only on the basis of a prostate biopsy. There's no wiggle room for the rater. The rater would not be the bad guy in this. There has to be a biopsy. So this is important when you're claiming it. If you don't have a biopsy, then it's premature to claim something. You should get a biopsy. If you've had a biopsy, then that needs to be a document of evidence that is submitted with your claim separately. It just needs to be uploaded with your claim or sent with your claim, showing that you've had a positive biopsy for prostate cancer. Because if not, then you'll get denied and you won't understand why. So here we talk about the exception. This has to do, now you know how up here I said this is for the initial prostate cancer. Well, once you've had prostate cancer diagnosed for VA purposes with a biopsy, let's say that they do a radical prostatectomy and they remove the prostate, but afterwards you have your prostate cancer had metastasized or moved to a different portion of your body. And the doctors find that you have cancerous prostate tissue in, like, let's say your pancreas. Well, you don't need a new biopsy to actually support a diagnosis after once the condition has moved or metastasized to a different part of the body, we can use PSA levels. Like we can just do that. It says here, when the initial diagnosis of prostate cancer was confirmed by biopsy and the evidence shows reoccurrence, so a new separate reoccurrence of prostate cancer following any kind of treatment, repeat of the biopsy is not required. But the initial biopsy is absolutely required. There's no wiggle room on that on the VBA side. So what we'll do here is we'll move on to kind of like what the treatments are. Now this gets a little bit complex. So if your doctor has said for your treatment, we're going to do watchful waiting. You have a confirmed biopsy, but we're going to do observation, surveillance. We're going to do just these things with no immediate specific therapy. So what happens is once you have active prostate cancer, you are to be granted at 100%. So typically you're granted at 100% while you're receiving treatments. But if you're still in a watchful waiting status, like that's the terminology that your treatment plan has for, what we're going to do, then what's supposed to happen is the rater, this is the rating considerations over here. So this is what the rater's meant to do. They're supposed to confirm and continue the active cancer, basically keeping you at 100% after it's been confirmed by the biopsy. And then we're supposed to set up a routine future exam to kind of evaluate in the future whether or not your condition has resolved, and kind of seeing what's going on. If watchful waiting is used to closely monitor inactive cancer that is in remission, evaluate based upon residuals. Okay. So this right here, and this is kind of hard to explain. This is why prostate cancer is so kind of complex. Prostate cancer has two different statuses in rating. Either you have active cancer or you have cancer in remission or it's gone. Active cancer is always 100%. There's no give on that. If you have active cancer, you're at 100%. It'll say prostate cancer 100%. But if the cancer is inactive, then what happens? We switch to rating residuals. Now, barring one single condition of erectile dysfunction, any residuals that you have from either the prostate cancer itself or the intervention that was used to treat the prostate cancer, while the prostate cancer is active, all those residuals are subsumed or combined under that 100% prostate cancer. Okay, so you can't get them separately granted out because you're 100% for the active cancer. And the only exception can be erectile dysfunction. Just putting that out there because we'll get to it later on. So while you have active cancer, everything gets just combined into this ball of you're 100% for everything related to cancer, prostate cancer. But whenever the cancer resolves, then that's why we give you a 6-month window after it resolves to keep paying you at 100% to kind of let the residuals see what is a residual and what's not a residual. And we'll get to that. But typically what happens is we will do routine future exams, either 12, 18, 24 months to see if the cancer's gotten better. And what'll happen is, let's say that your treatment has resolved. We give you 6 months of 100% for the prostate cancer for that 6 months to see kind of how the chips fall on your residuals. But for watchful waiting, we're just supposed to, if the cancer is inactive, then we just evaluate based upon the residuals of the prostate cancer, which is fairly normal. Now, this is an actual intervention where we do radical prostatectomy surgery, where they remove your prostate. Now, one of the problems with this is that the medical side, like the non-VA medical side, that's a precaution that they like to do when you have high PSA levels. So if you've declined your biopsy and you opt for a radical prostatectomy, then there's no way to confirm the cancer diagnosis for prostate cancer. We need the biopsy. And if they remove the prostate, then there's nothing to biopsy. So there are a lot of veterans who have unfortunately fallen victim to the VA's, uh, I want to consider unreasonable requirement of having a biopsy because it's not what the medical science dictates is a good way to diagnose it. So, if you are a veteran who has had a radical prostatectomy and has been denied for no diagnosis, then I would probably take your appeal to the BVA because they don't have the same. I want to say they don't have the same requirements for this of it being having a biopsy because this is just for non-medical professionals. Like the M21 manual is to show is to kind of draw lines in the sand of what, so that way there's no anarchy among the staff. They just say, okay, because there's so many different ways somebody could qualify that that the veteran has prostate cancer, we're going to put this limitation that they have to have the biopsy in order for you to kind of grant it. Because what was happening is benign prostatic hyperplasia was being treated a lot like prostate cancer. So they would just kind of treat them similarly. I'm not making an excuse for it. But if you're somebody that falls within this category of you never got a biopsy and you had a radical prostatectomy and you can't get your prostate cancer granted, I would probably go to the Board of Veterans Appeals, get an attorney, and then try to take the fight there. Just my advice. So when you have a radical prostatectomy, it's characterized by the removal of the prostate gland completely. Now, this is just kind of medical talk, but a radical prostatectomy is like the complete removal. There's things called TURPs and whatnot, which are partial removals, or there's different medical procedures, but the only one that we're talking about here is the radical. I removed all of the prostate out of your body. So, this is the most common treatment for localized cancer, and being the most common treatment, it's a knee-jerk response for most medical doctors. That's why if they start to see elevated PSA levels, they will opt to want to try to remove the prostate. And that's great medically, but not good for the VA. So what happens in the case where there's been a radical prostatectomy? So this is a surgical procedure. So if you had that and they removed the prostate and you were deemed to be in remission, then, or if they just did it, the rater can actually award SMCK for loss of use of a creative organ. And we can also consider erectile dysfunction on the facts found. So this is the exception to that, that if you have active cancer, we can't assign a secondary residual to your prostate cancer. In the only exception is ED and like radical prostatectomy or radiation therapy, I believe, but we'll get to it. But if you are now, one of the confusing things that when people read this is they think that they get two separate SMCKs. They don't. You get one for this particular. You'll either get it for just loss of the creative organ or loss of use of the creative organ. But it's still going to be for the same thing. And to give two separate ones would be pyramiding. So we can't do that under 38 CFR 4.14. Now, should you have cryotherapy? I haven't come across a lot of this, but the prostate tissue is frozen in liquid nitrogen. I mean, it can cause these kinds of symptoms here. So when it's time, if it does cause impotence, this would be loss of use of a creative organ. So SMCK based upon the facts found, like if the veteran should have erectile dysfunction due to the cryotherapy. Yeah. So this can be granted while under active cancer also. So now radiation therapy. So radiation therapy, external beam of radiation, this is mostly scientific. These are the things that can happen. So these are kind of leaning into and teaching the rater as to what the potential residuals could be: bowel incontinence problems, urethral complications. So sometimes the prostate cancer itself can have residuals, but also the interventions or treatments that were used to treat the prostate cancer, can they themselves create, as kind of an intermediate step, they can create residuals. So prostate cancer is usually a duration-based thing. So we're looking mostly at, you will know how long you're supposed to have like 15 procedures for it, and afterwards they'll review and see if you still have it. So this is going to be one of the ones where after the radiation stops, you get 6 months of additional 100% pay uh, in order to see how the residuals kind of, like, what develops afterwards. So after the initial radiation therapy, we're to assign that 6 months of temporary 100% under this diagnostic. And we're also supposed to consider SMCK for, impotence. The reason why they keep saying this is because SMCK should be something that the rater can reasonably raise in a prostate cancer situation. The problem is that raters rely on the VBMS system to typically raise SMCs that qualify under the situation, but VBMS is not good at raising prostate cancer because it's supposed to be based upon the facts found. So the system doesn't raise automatically SMCK to say, hey, rater, should you consider this? So it'll keep saying this because it's meant, when you're rating something, you should go to the section that is about in the manual that's about the disability that you're reviewing and see what the I must do this, I have to do this, because the manual updates all the time. So you've got low dose radiation, high dose radiation. So after high dose radiation, this is what you're supposed to consider. 6 months, temporary 100% after it concludes, and then consider SMCK and additional residuals once the radiation is resolved. This is going to be a long video. Low dose radiation. So we're supposed to assign the 6 months, assign a 100% for 1 year following the completion. So the 6 months is not set in stone. For low dose radiation, it is actually going to be 1.5 years. So I've never granted under low dose radiation. I've only granted under high dose radiation. So that's why the facts found matter. Hormone therapy is kind of weird. If you're somebody on hormone therapy, this is one where sometimes you'll see people with prostate cancer, post-active prostate cancer, where they have it, they're on hormone therapy and they get 100% for the rest of their life. And the reason why is because the hormone therapy is prescribed for the rest of their life. So they're always going to be in that, I'm still being treated for the condition of prostate cancer. So here's a few different types of therapies just for your own personal, like, does this apply to me? Different hormones. These are some examples. These are not an absolute list. So if you have other drugs that are prescribed for hormone therapy for, the prostate cancer, you can run it by your VSO, even though they probably won't know, but it's possible that you can get it granted. So, and then here's just more. It's just all over the place. There's a lot of different, and this is where the struggle is real for the raters, because you have to point this out to the rater. You have to point out that you're on hormone therapy to the rater. Do not assume that your rater has an MD behind their name and that they know what drug is associated with what thing. So it would behoove you, if you're a veteran who has had prostate cancer or in current treatment with prostate cancer, and you're on hormone therapy from your doctor, then you need your doctor to explicitly state, hey, the veteran is on hormone therapy for this long. This is the duration of the hormone therapy, yada, yada, yada. So these are the symptoms that are kind of associated with hormone therapy. And some of these are things that you can get second, like if the hormone therapy should stop, then we'll rate for residuals, and these are just some of the residuals associated with them. Now, this is going to be specific to the types of therapy. So if you had this particular removal of the testes, then we would consider for evaluate under this particular, evaluate the residuals and then award SMC for loss of a creative organ because they removed your testicles. This is going to probably be 6 months after the procedure is done. So the 100% will be taken away and the residuals will kick in. Now, if you're on just normal chemical hormone therapy, like this kind of chemical hormone therapy, then you're going to be 2 years. Like we will typically kick out a routine future exam 2 years afterwards, and then we'll kind of see what's going on and how things are going. But as you can see here, hormone therapy can be considered permanent. If your doctor says it's going to be happening for the rest of your life, then we can consider permanence for hormone therapy for prostate cancer. So you can be the 100% for the rest of your life. And then we got chemotherapy. Oh, this is going to be a long video. So chemotherapy, depending on the type of chemotherapy used, can have multiple side effects. Once your chemotherapy has resolved, you're looking at 6 months after the chemotherapy is resolved that we will rate residuals. Now, if you are someone who has been treated with chemotherapy for prostate cancer, you will want to have your doctor explicitly identify the types of side effects that are associated with your specific chemotherapy, so that way you can submit that on your behalf whenever you have your reevaluation or your routine future exam. When you go into remission 6 months following that, what'll happen is that way we can get your residuals rated, I guess is what I'm trying to say, in the longest way possible. So chemotherapy is kind of weird. Metastasis can happen no matter what therapy you're using. So this is metastatic disease, basically says that the prostate cancer has moved to another body system or to another part of the body. And you actually have prostate cells, the cancerous cells that are now growing in a different section. They've gotten into the bloodstream and they've moved. That's how that works. So it says that if that should be the case, then what happens is we can rate you for 100% for that new type of cancer. So like, let's say you've got active prostate cancer and you're on chemotherapy, we'd rate you 100% for the prostate cancer and you're being treated for, with the chemotherapy. Let's say that your prostate cancer metastasized to your liver. Well, then we would grant you 100% for liver cancer, secondary to the actual prostate cancer. And that can happen as many times as it metastasizes. And there is a value added to that horrible situation, is that you would get SMC S1 at that point in time, because you'd have a single 100% and you would have a separate thing above 70%. So, all right. So moving on here, and I know that this is long-winded, guys, and I'm sorry. This is why I said that you're probably gonna have to watch this twice, because it's very complex and it's very situational. Now let's move on to my handy dandy little exposures dependent upon thing here. So what happens here is, what theories for service connection can prostate cancer be granted under? And then, is a medical opinion required for this? I thought that you might like this, so I just added it in. So what we have here is the direct theory. So like, let's say you were in service, active duty, or Title 10 orders, and you get diagnosed via biopsy with prostate cancer. That can be granted. A medical opinion will be required, but I'm going to say that one's on rails, right? It pretty much will be instantly granted, because there's no, it's prostate cancer. You don't just get cancer from falling down the stairs. Another one which is exceedingly unlikely, like this is nearly impossible, but I'm just going to say it. If you had prostate cancer before service and you got it treated, and let's say it went into remission and then you joined the military, and let's say that you had metastasis, right? Like where prostate cancer got into your bloodstream and moved to somewhere else, like your bone, and then you later on in the military found that you had bone cancer. This is going to be one that I've never seen before, but it's like statistically it's possible that this could happen. But you'd have to show how the military made your prostate cancer worse. So this would be heavily dependent on the medical opinion given. I'm just putting it out there because technically it's possible, and I'm just throwing out technicalities. Now, presumptive due to Agent Orange exposure, 38 CFR 3.309E. That's going to be what the majority of veterans, Vietnam era veterans, that's what they're going for. So once again, you need the prostate biopsy. All of these require the biopsy, by the way. And there's going to be no medical opinion on this because it's presumptive to Agent Orange exposure. So element 2 would be, did you go somewhere or can you prove that you were exposed to Agent Orange? And if you were exposed to Agent Orange, then there's no medical opinion. Now, relatively recently, we've had 38 CFR 3.320 burn pits or airborne hazards with the PACT Act. So the PACT Act brought in a new type of cancer that can be presumptively granted under the airborne hazards. So it's under the reproductive system, like a reproductive cancer. This would be the same as the Agent Orange, where there's no medical opinion required. And then we come down here to Terra exposures. Now, this is going to be kind of confusing. So there's going to be certain locations that have presumptive exposures to chemicals that the VA concedes as being presumptively can cause prostate cancer. That's fine. That's what these two are. However, this one's where, hey, I was exposed to a chemical. It's not one that's presumptive. It's not something that is presumptively able to be granted, but I was exposed to this chemical. Let's say JPA. You get an examination and the doctor is going to have to do a medical opinion and determine whether or not the specific chemicals that you were exposed to could have caused the prostate cancer. That's going to be a mixed bag because there's no certainty there. Now, I want to also say that let's say that you can be granted for multiple, like you qualify under multiples of these. What should happen is the rater is going to take the most advantageous one. Presumptives are the most advantageous. The rater should look at the presumptives first. If aggravation, actually, let me take that back. If aggravation is an actual thing, which I don't think it is, the rater has to look at this first. This is actually the tippy top first thing because aggravation under 3.306 limits the condition to only being granted under the aggravation theory. The second thing they'll look at is they'll look at presumptives. Did the veteran's circumstances of service put them in Vietnam, or did it put them in Southwest Asia during a qualifying period of time? If so, the rater will go with this. The next one in line is direct theory. Is there anything in the STRs that show that the veteran has or had prostate cancer via biopsy, confirmed in service? And then the last one that they're going to look at is Terra. Okay, that's just the order of operations that the rater do. We're at 29 minutes and we're not even there yet. Okay. Prostate cancer is actually rated under 7528 malignant neoplasms of the genitourinary system. And this is where you're going to see a lot of people go to. And this is going to be where these are the types of interventions, therapies, and or treatments that count towards you having active cancer. Even if you're in remission and you're still receiving these treatments, you would still be rated at 100% because you're still being treated for the condition. The VA examination, okay, so the VA shall continue you at 100% with a mandatory VA examination at the expiration of 6 months following the cessation of any of these treatments. Now, as you saw beforehand in the M21, there are some exceptions to this. So this is the rule, but the M21 has exceptions that the VA has conceded that they'll do, like the year and a half for the cryotherapy, I think, and then like the 2 years for the hormone therapy, because they can take a lot longer to resolve. Um, any change in evaluation based upon that or any subsequent examinations shall be subject to the provisions of 38.3.105E. So, what this is saying is they're saying that we can't instantly reduce you. We're going to propose to reduce you based upon the change in circumstances of your DBQ. You'll go for a routine future exam. And then once you're at that routine future exam, if your status should change from active cancer to in remission, then that's when we're going to start calculating the residuals and we're going to propose to reduce. Then we're going to give you a month's, 30 days time. It's 60 days, but 30 days, honestly. Because, so you have 60 days to respond back and do a hearing. And if you do that within 30 days, then we keep you at 100% throughout the whole duration of the hearing. If you take longer than 30 days, then we drop you down to what we're proposed to drop you down to while we're doing the hearing, is kind of the way that works. So we propose to reduce, which it allows you to get evidence to say, I'm still on this particular treatment right here. You shouldn't reduce me yet because I'm still being treated for the condition. Or I have a new active cancer diagnosis, or my cancer is metastasized. Whatever that fact pattern might be for you, the proposal to reduce gives you the opportunity to tell the VA that, because obviously like 12 months, 18 months, 24 months have passed since the last time you had an examination. And a lot of veterans receive treatment in the private sector, and they like when they do a routine future exam, they oftentimes don't get those records in time. So the examiners might not be going off the most accurate information. So this particular, how is it rated? Relatively quick here. It's 100% or it's not. Because if it's not, then there's no local occurrence, there's no metastasis, then we rate the residuals as voiding dysfunction or renal dysfunction, whichever one makes the most sense based upon your evidence. And that's it. So let's move on to the DBQ. So prostate cancer is going to be determined under male reproductive condition, including prostate cancer. I'm going to go through this relatively quick because we'll be here forever. So the same as every other one, the evidence has to match up here. We're looking for evidence review. If you have private records, we want to make sure that the person reviewed your private records on here. Diagnosis, this is going to be important. Does the veteran now or have they ever been diagnosed with any, this should be yes. I mean, it's stupid. We're also looking for the examiner. Like if you have residuals, you might want to tell them about it so that way they can, report it. This is what we're looking for here. Neoplasms of the male reproductive system, including prostate cancer, that diagnosis, date of diagnosis, that matters. This is going to be a section where they're going to put more, like any other residuals, they can kind of flesh that out a little bit here. Medical history matters because we want to know about the medical history of your treatments, because that's what the rater's using to kind of determine when we turn off, or if we even have to turn off the 100% and start transitioning into the residuals. So if this is a private DBQ, then you need to make sure that this is dress right dress as best that you can. Continuous medication, that would be an important thing. Like if you're taking hormone therapy for it, then I would want to see that right here. These have to do with specific individual treatments. For treatments of the prostate, for prostate cancer, we want to know the dates and times, when it started, when it ended. That's going to be some of the most important stuff. Now, this section of the male reproductive is for residuals. So We expect that the examiner will fill this out. Even if you're still on treatment, we want them to fill this out just for substantial completeness. So if you're doing a private DBQ, don't just say that he has active cancer and then just leave it at that. Have all of this filled out, so that way it starts establishing evidence of what potential future residuals could be. Erectile dysfunction is important because, like I said beforehand, erectile dysfunction is the exclusion to the rule that you can grant erectile dysfunction secondary to a procedure that was used to treat the prostate cancer. And then we come down here to physical examinations. We're looking for the neoplasms, malignant neoplasm section. Prostate was not examined, should not be. Tumors and neoplasms. So this is the section that the rater is going to be going to, especially on routine feature exams. So this should always be yes, because it is currently, or have they had it? And you should have had it if we're doing like a routine feature exam. Now, malignant, active, that's going to be 100%. Like that's just 100%. We'll schedule you for a routine feature exam, be it 12 months, 18 months. 18 months is a pretty normal amount of time. Primary or secondary has to do with the metastasis. So what it should look like is active primary. If we have had metastasized where it's moved to a different part of the body, then we will have that also. Okay. If they should mark in remission, it doesn't necessarily mean that we're going to cut off we're going to propose to reduce right away. We're going to look for the dates of your treatment. Has a veteran completed treatment or undergone treatment? So this is going to be yes. Watchful waiting, as you recall, watchful waiting has its own little thing to where it can still be considered 100%. So some raters, for whatever reason, they do not get that. And then we're going to say treatment was completed. Dates and times matter because 6 months, or depending on what the treatment was that you were given, it's going to tell us how long we're going to give you that extended period of 100%. Okay. These are some of the interventions. This is the TERP that I was speaking about, where it's not a total radical prostatectomy. So if they mark this, you don't get the radical prostatectomy. It's just a different thing. So if you're having a prostatectomy, it's a radical one, date of surgery, those are going to be the ones, like I said beforehand, this is one of the ones that plague a lot of veterans, especially like Vietnam veterans, where they just went with their doctor's advice to get the radical prostatectomy without doing a biopsy, and it hurts them. So VBA. So anyway, you have the diagnosis section here. Does the veteran currently have any residuals? Okay, that should be yes or no, depending on what's true. But if it's yes, then we need to know in detail what they are, because this is going to be like a medical opinion. So this is where the doctor gets to say what residuals are attributed due to complications of the neoplasm, or residuals or neoplasm. So this is like a medical opinion. Anything that they put in here is them conceding that this is caused by the prostate cancer or the treatments in the pursuit of curing the prostate cancer. And then this is about metastasis. So if the prostate cancer is moved, please identify where it's moved to. Findings, facts, diagnostic testing. Okay, this is the most important section in here. If you're doing a private DBQ, this has to be yes, and the biopsy date has to be on there. And you have to tell us where you got it from. You have to provide evidence showing that it happened. You have to provide evidence showing the conclusion of the biopsy. It has to happen. Now, in routine future exams, after we've proven that fact, you're not required to have to do that. It's just that initial diagnosis, initial granting, you have to do that. Okay, guys? Functional impacts, not really that important for this section. The remarks section can be important, especially if you're on hormone therapy. I would want the doctor to talk about like what the duration of the hormone therapy is, or if it's going to be constant for the rest of your life. Then I need them to put that at the top so I can read it. So that way there's less chances for raters to top sheet and not see that. Same as it always was on this section, you need to make sure that your examiner's information, if you're doing a private DBQ, that their NPI number matches the NPI registry information matches what their current stuff that they put on here is. If they put an address on here and that address doesn't match what's on the NPI registry, then your private DBQ can be basically disqualified as being insufficient for rating purposes because it's inauthentic, because we can't confirm that this provider is the same provider that has that number, or that they're still in good standing with their licensure, because they probably haven't updated it in a while. All right. So this is an example real quick of what a staged cancer evaluation happens. What it looks like, basically, because we have this really weird dynamic with prostate cancer where you start off at 100% and then you're either stay at 100% for the rest of your life, or else we'll titrate it down to residuals. So I'm not going to go through this. This is just an example of how the original claim, and you needed to have a biopsy for this, but yeah, you originally claimed it prostate cancer 2012. At that time, it was active cancer confirmed by a biopsy. Prostatectomy was performed in 2012. Follow-up evaluations indicate no, sure, treatment was needed. VA examination conducted June of 2013. So this is where they did a 12-month routine future exam. So this is where they did a routine future exam from this date, did it 12 months out. The examination confirmed the cancer had not recurred or metastasized. The exam findings were notable only for subjective reports of urinary frequency, daytime voiding. So this is a residual. The examiner reviewed treatment records. Private urologist, oncologist noted exam findings were consistent with the findings of all the private reports for the last 8 months. For this scenario, all evidence is reviewed for the original rating for the claimed prostate. So what the result is award 100% from the date of claim, or intent to file, whatever that would have been. We're going to propose to reduce, but the reduction should happen December 20th, 2012, 6 months after the cessation of the treatment for the malignant neoplasm. So it'll be like 7 months, because we give you that. If treatment ended on like December the 11th, right? We're going to start that 6 months on January to February, February to March, because you can't half month something. So, oh man, this is a long video. Okay, so that's what I want to show you on that. This is kind of like how the facts play out. And then this has to do with, why did I bring this up? Oh, this is intertwined issues. Okay, so this is something that where the rater's hands will be tied in some situations where we can't, like if we have an active claim for something, like you can't claim erectile dysfunction if we're still trying to prove the primary condition is granted or not, is basically what happens. So what we typically do is, if you were to have prostate cancer trying to be service connected, and you're trying to appeal erectile dysfunction, we'll basically defer the condition until the prostate cancer gets resolved. We'll defer the erectile dysfunction just because it's not a good idea. And this has to do with multiple factors, but I'm just talking about intertwined issues right now. And the video is too long for that, but I will go ahead and end it here at 44 minutes. So I apologize if this was really, really long, but it needed to be that long. So I would like to take the time to thank you if you made it to the end of the video. I'd like to say, if you have this much endurance, then I want to just pressure you into maybe hitting that subscribe button if you like this kind of content, because it's more of a TED Talk. It's not entertainment, it's actually education. And I know, guys, some people have said, hey, look, can you make the video shorter? And I'm like, it needs to be as long as it needs to be, because I'm not trying to get you on views or anything like that. What I'm trying to do is educate. So I'll probably break this video out into more bite size, but I wanted to do kind of a macro video first. So anyway, that is about all I've got for you today. Me and the dogs would like to thank you for watching. Have a wonderful day. Raider out.